All right. Welcome to the deep dive. You've sent in some really interesting sources, and the topic sounds quite specific at first, but I bet there's more depth here.
hmm
We're looking at something called Large Ovary Syndrome in mares today.
Right. And that name, Large Ovary Syndrome, LOS, it's
Yeah.
important to know right away it's not like a single specific medical condition, not really a diagnosis in itself.
Ah, okay. So more of a description.
Exactly. Think of it like an umbrella term. It just means one or both ovaries are, well, larger than you'd typically expect. But why they're bigger?
Well, that's the crucial part, isn't it? Because the reason could be anything from, perfectly normal body changes to something quite serious pathologically.
That's a really vital distinction to make right off the bat. So, our mission here for this deep dive is to kind of pull out the key takeaways from your sources, help you get up to speed quickly without getting bogged down. We're going to unpack what large ovaries actually means, how you tell normal from, well, not normal, and what it really means for the mare's health. Yeah, and the source material you sent is fantastic for this. It gives a really comprehensive look, the basics, the causes, diagnosis, treatment, even the prognosis. It sets us up nicely.
Okay, let's dive in then. Let's start with the basics. What do we even mean by large when talking about a mare's ovary? And critically, when is being large actually completely normal? Because mare ovaries are pretty dynamic structures, right? Their size changes quite a bit.
Oh, absolutely. They're naturally quite large compared to some other species, and their size fluctuates significantly. Think about the estrus cycle, the heat cycle, and seasonality plays a huge role too. It's not unusual at all for a normal, mature follicle, that's the structure containing the egg, to get up to 5 or 6 centimeters, maybe even bigger, just before ovulation.
5 or 6 centimeters. Wow, that's pretty substantial.
It really is. And you mentioned seasonality, that's key. The length of daylight is the main driver, the main switch for ovarian activity in mares. They're generally cycling, having their heat cycles in the spring and summer. Outside of that, things tend to quiet down. In fact, after the winter solstice, the shortest day, there's usually a lag time, maybe 60 to 90 days, before they even start cycling regularly again.
Okay, so normal large structures include those dominant follicles getting ready to ovulate. What else contributes to size normally?
Well, after ovulation, the structure that forms is called the corpus luteum, or CL. That also adds to the overall size.
Right.
And then think about pregnancy, especially in early pregnancy, maybe after about 37 to 40 days, mares develop both primary and accessory CLs. This causes both ovaries to enlarge bilaterally enlarged ovaries.
Both sides get bigger then.
Yep. And here's a really interesting thing during pregnancy. The fetus's own developing gonads can actually cause the mare's testosterone levels to rise, sometimes quite a bit.
Wait, really? The foal influences the mare's testosterone.
It can, yeah. Sometimes peaking around 200 days gestation. And this can occasionally lead to behaviors that look like stallion-like aggression. You might mistake it for signs of certain tumors, but nope, just pregnancy hormones.
That's genuinely surprising. So a pregnant mare acting a bit skittish might
Uh,
just be the pregnancy itself. Good to know.
It's definitely something to keep in mind, yeah. It just highlights why you need a proper diagnosis. Now, you also asked about those transition periods seasonally, spring and fall.
Yeah, tell me about those. That seems important.
Super important, because this is where we see the most common cause of so-called large ovary syndrome. During these transition times, mares often develop multiple large follicles, but these follicles just fail to ovulate. They stick around.
So they get big but don't pop,
Yeah,
basically.
exactly. We call them persistent follicles, and they are, hands down, the number one reason vets encounter enlarged ovaries in mares. But here's the thing. They are actually normal structures for that time of year. If you just leave them alone, they will eventually resolve.
Okay, so if a mare has these persistent follicles, what would the owner actually see that might cause concern?
Well, it's seasonal, so you'd notice it in spring or fall, typically. The mare might seem like she's in heat for a really long time, maybe longer than the usual 12, 14 days, especially in spring. She might be very receptive to the stallion for ages. On an ultrasound, the vet would see several follicles, different sizes, but they grow slower than a typical dominant follicle would right before ovulation, maybe just 5, 6 millimeters a day.
And what's the underlying reason for this? Why do they persist?
It's all tied back to day length and hormones. In spring, there might not be quite enough of the hormone LH, luteinizing hormone, to trigger ovulation. In the fall, LH levels are naturally decreasing, and it's incredibly common. Some estimates suggest maybe 80% of reproductively normal mares go through this.
80%? Wow, that puts it in perspective. So for owners, seeing a long heat cycle in spring might just be normal transition stuff.
Very often, yes. And in terms of treatment, often the best approach is just time, patience. They will resolve.
Just wait it out.
Exactly, but if you need to manage it, perhaps for breeding purposes, there are options. Vets can use hormonal treatments to help shorten that transition period. Things like daily Regumate for about 15 days, or maybe an injection of HCG if there's a follicle over 35 millimeter. Other drugs like Deslorelin or a progesterone estradiol combo. There are ways to intervene if needed.
Okay. And the prognosis for these persistent follicles is good then?
Perfect. 100% resolution with time and the change of seasons doesn't affect future fertility at all.
Okay, that covers the normal reasons really well. So now, let's get into the situations where large is a red flag, the pathological causes. What's next on the list after persistent follicles?
The second most common cause would be an ovarian hematoma.
Hematoma, like a bruise.
Essentially, yes, a very large internal bruise or blood clot within the ovary. It happens after ovulation when the structure that forms, the corpus hemorrhagicum, bleeds excessively into itself.
Okay, excessive bleeding post-ovulation. Does that happen on both sides?
Usually not. It's almost always unilateral, just one ovary affected. The other one looks normal. Sometimes the mare might show signs of colic, like acute pain, very short-lived because the ovary is stretching so rapidly. But behaviorally, after ovulation, she'll usually be in distress, rejecting the stallion like normal.
And how does that look on ultrasound? How do you tell it apart?
Acutely, right after it happens, it looks like a fluid-filled space. But then, over the next few days, maybe 2 to 10 days, you start to see brighter, hyperechoic areas as the blood clots. Eventually, it can look quite a bit like a large CL, and blood tests will show progesterone increasing by about day 5 to 7 post-ovulation.
Okay. And treatment for a hematoma. What's the plan?
Most of them actually resolve on their own with just conservative management. Basically, watch and wait. Sometimes a vet might give an injection of PGF2, that hormone that helps reset the cycle, but the ovary might take a while to fully luteinize, so the response might be a bit delayed, maybe 6 to 14 days or more.
And the long-term outlook.
Excellent. Excellent for survival, excellent for future breeding. They usually resolve within, say, 1 to 6 months. It's very rare for repeated hematomas to cause lasting damage.
Right, that's reassuring. Now, moving into tumor territory. The one that comes up most often seems to be the granulocytica cell tumor, the GCT.
Let's really unpack this one.
Yes, definitely. This is the most common ovarian tumor we see in mares. Still relatively rare overall, maybe 2.5% of all horse tumors, but definitely the most frequent ovarian one. And a really key feature, GCTs are almost always unilateral. Only one ovary is affected.
To one side again.
Exactly. And crucially, the other ovary, the contralateral one, typically becomes very small and inactive. It gets shut down.
So one huge ovary, one tiny inactive one. That's a major clue right there.
A huge diagnostic clue, absolutely. Now, the good news is most GCTs are benign. They grow slowly, and the risk of them spreading, metastasizing, is low.
Okay, mostly benign. But they cause problems because they're hormonally active, right? Precisely. They often produce a cocktail of hormones. One key one is inhibin. Inhibin suppresses FSH, the follicle-stimulating hormone, and that's what causes the contralateral ovary to become inactive. They also frequently produce testosterone. That's why you can see that stallion-like behavior. Or sometimes they produce estrogen.
Which explains why the symptoms can be all over the place. What kind of things might an owner notice?
Exactly. The signs are highly variable. Probably the most common sign is actually anestrus. The mare just stops cycling altogether. No heat cycles.
Okay, lack of cycles.
But you can also see the opposite persistent estrus, sometimes called nymphomania, where she seems to be constantly in heat. And then there's the classic stallion-like behavior, aggression, mounting other horses, trying to herd them, maybe even developing a thicker, crusty neck or more muscle mass.
That's quite a range. Anestrus to nymphomania to acting like a stallion.
It really is. Less commonly, they might show some pain, maybe discomfort when ridden, especially at the trot or refusing jumps, just due to the physical stretching of the ovary and its attachments.
So with such varied signs, diagnoses must be really key. How do vets actually pin down that it's a GCT?
It's definitely a process, and it's important owners understand why multiple steps might be needed. You don't want to jump to surgery unnecessarily. It starts with transrectal palpation. The vet feels for that single enlarged ovary. Often it feels smooth. The normal ovulation dip or fossa disappears early on, and they feel for that small, inactive opposite ovary. That comparison is critical.
Palpation first. Then imaging.
Yes, then transrectal ultrasound. That's your main visual tool. GCTs often have a classic appearance enlarged, multiple fluid-filled cysts, giving it what vets describe as a honeycomb or Swiss cheese look.
Honeycomb, yeah.
Though it's worth noting, sometimes they can look more solid, or even be just one single large cyst. The appearance can vary a bit.
And you mentioned hormone tests are vital.
Absolutely crucial. Hormonal analysis from a blood sample is really the clincher for diagnosis. And the gold standard test nowadays is anti-Mullerian hormone, AMH.
AMH. Why is that the best one?
It's incredibly sensitive, picks up something like 98% of GCTs. Levels are usually significantly elevated, often 5 times normal or much, much higher. And a huge advantage is that AMH levels are stable. They don't fluctuate with the mare's cycle or with pregnancy like some other hormones do. Makes it very reliable. High AMH is a very strong indicator.
Okay, AMH is the go-to. What about the other hormones you mentioned, inhibin and testosterone? Do they still measure those?
They definitely still play a role. Inhibin levels are elevated in maybe 80% of GCT cases, so that's highly suggestive too. And testosterone is high in about half the mares, especially as you'd expect, the ones showing that stallion-like behavior. While AMH alone is often enough, sometimes vets will run a panel checking inhibin, and testosterone too can increase diagnostic confidence to around 84%, especially if AMH is maybe borderline.
Oh.
And importantly, progesterone levels are usually low, less than 1 ng/ml with a GCT.
Got it. So AMH is key, others add confidence. Once you have that GCT diagnosis, what's the treatment?
The treatment of choice is surgery. Unilateral ovarectomy, meaning removing the affected ovary.
Just the one with the tumor?
Yes, just the affected one. The surgical approach depends a bit on the size of the tumor. For many, a standing flank surgery, maybe laparoscopic, works well. For very large tumors, sometimes a ventral midline approach under general anesthesia is needed. Or for smaller ones, sometimes a colpotomy approach through the vagina is possible.
And the big question for owners, the prognosis after surgery.
It's actually excellent for survival. Like we said, these are almost always benign. They don't tend to spread. And the prognosis for returning to breeding is also good to excellent. That suppressed ovary, the contralateral one, it usually wakes back up.
Oh, good. How long does that take?
On average, maybe 6 to 8 months after the surgery, she'll start cycling normally again. The range is pretty wide, though. Could be as quick as 2 months or take as long as 18 months. But the behavioral problems typically resolve, and most mares can successfully conceive and carry a foal afterwards. So while it's a serious thing, the outcome is usually very positive with surgery.
That's great news. Okay, besides the persistent follicles, hematomas, and GCTs, are there other, maybe rarer things that can cause large ovaries?
Yes, there are a few others worth mentioning. One is the hemorrhagic anovulatory follicle, or HAF.
HAF. Sounds a bit like the persistent follicle.
It's similar in some ways. It's also common during transition seasons or in older mares. A follicle develops but fails to ovulate, then it bleeds internally, like a hematoma. But it also partially luteinizes, starts acting a bit like a CL, producing some progesterone. These can get quite large, maybe 4 to 7.5 centimeters. They might make a cycle longer, but usually don't cause specific behavioral changes. Progesterone might be elevated. Most HAFs regress on their own in 1 to 7 weeks. Or if it's luteinized, TGA2 can help speed things up. Prognosis is excellent.
Okay. And any other rare tumors?
Yep. The second most common, though still rare tumor, is the teratoma.
Teratoma. Sounds familiar. Are these the weird ones?
They're definitely unusual. They're usually benign, like GCTs, and typically hormonally inactive. So the other ovary often keeps cycling normally, and the mare's behavior is usually fine. But they can grow very, very large and cause discomfort or colic just due to their size. And on ultrasound, well, they arise from germ cells, cells that can become anything. So you might literally see structures inside that look like hair or teeth or fragments of bone.
Wow. Hair and teeth inside an ovary.
Yeah.
That is wild. Why does that happen? Is it like a misplaced twin or something?
Not quite a twin, but it comes from those very primitive germ cells that have the potential to form any tissue type. So you get this jumbled mix of tissues. It's a fascinating developmental glitch, really.
Bizarre, but usually benign, you said.
Usually benign, yes. Treatment is surgical removal, and the prognosis is excellent.
Okay. Any other really rare ones to be aware of?
A few more, quickly. Dysgerminoma is rare, usually unilateral, hormonally inactive, but unfortunately often highly malignant. It tends to metastasize. Signs might be vague chronic colic, weight loss, stiffness. Prognosis is grave to poor.
Oh, that's tough.
Yeah. Then there's cystadenoma. Rare, usually benign, slow-growing, unilateral, doesn't affect the other ovary or behavior. Surgery is curative, prognosis is good.
Okay.
And finally, an ovarian abscess. Also rare, usually from an infection getting into the ovary. You'd see signs of infection fever, maybe colic. The ovary is often painful when palpated. Treatment usually involves removing the ovary, maybe long-term antibiotics. Prognosis is more guarded to good, depending on the infection.
So quite a list. From completely normal things like persistent follicles to benign tumors like GCTs and teratomas to malignant ones like dysgerminomas and then infections.
Exactly. Which really brings us back to the importance of diagnosis, doesn't it? We've discussed all these possibilities.
Yeah.
How does a vet actually sort through them? It's not always straightforward. It really emphasizes why vets need to explain to owners that it might take a few steps, repeat exams, those hormone tests to get the right answer, and avoid doing, say, unnecessary surgery for something like a persistent follicle that would resolve on its own.
Right. It's not just a single blood test or one look on the ultrasound necessarily.
Yeah.
You have to piece together the puzzle.
Precisely. You start with the basics. The clinical history. What's the mare's age? Her breeding history. What behavioral changes have been noticed? Aggression. Lack of cycles, constant heat, any physical changes like weight loss or a crusty neck.
Gathering all the clues.
Then the transrectal palpation. That initial feel gives information on size, consistency, whether it's painful, and crucially, that comparison between the two ovaries is one large and one small. That asymmetry is so important.
And then the ultrasound you mentioned provides the inside view.
Exactly. Transrectal ultrasound is the primary imaging tool. That's where you see the internal structure. Is it cystic? Solid? Does it have that honeycomb GCT look? Does it look like fluid and clotting blood like a hematoma? Or can you see weird things like hair and bone suggesting a teratoma?
Seeing is believing, or at least diagnosing in this case.
And finally, tying it all together are the hormone tests, especially for suspected GCTs. That AMH level, maybe inhibin and testosterone too. By combining the history, the palpation findings, the ultrasound images, and the hormone results, the vet can build a strong case for one diagnosis over the others and recommend the right plan.
So wrapping this all up,
Yeah.
what's the big picture takeaway here? This term, large ovary syndrome, it really just underscores how vital it is to dig deeper and to find the actual root cause. Because what looks like one problem on the surface could be, as we've heard, many different things, each needing a different approach.
That's the absolute core message. Large ovary syndrome is a sign, a presentation. It's not the final diagnosis. A thorough workup using palpation, ultrasound, and especially those key hormone tests like AMH for GCTs is just essential. And it's reassuring that the vast majority of cases are those normal persistent follicles or those generally uncomplicated hematomas which resolve naturally or need minimal help. But being able to identify the rarer, more serious conditions like GCTs early means you can intervene appropriately, often with surgery, and achieve an excellent outcome.
It really shows, doesn't it? Whether you're directly involved with horses as an owner or vet student, or maybe you're just fascinated by biology, how powerful it is to ask why. To look beyond that initial symptom, understanding these kinds of details, these nuances, can genuinely make a world of difference for an animal's health and future.
Absolutely. And maybe just to leave you with a thought, if we think bigger picture, how many other syndromes, maybe in veterinary medicine or even in human medicine, are also these kinds of umbrella terms, covering a whole spectrum of distinct conditions that actually need quite different management once you really understand the specific why behind them?
That is a fascinating question to ponder. Makes you think about how we label things. Well, thank you so much for sharing your sources and for joining us on this really informative deep dive today.